So just a minute after 12 o'clock, I think we'll go ahead and get going today. Hi, everybody. Good afternoon, and thank you for joining us for today's Palliative Care Echo series. A lot of new faces out there, so again, welcome, and so glad you could join us. So I'll start off with introducing myself and introducing Echo a little bit to for those of you who might not know it. I am Troy Jorgensen. I'm the program manager for Project Echo Nevada, based at the University of Nevada, Reno School of Medicine. And ECHO is a telehealth or telemedicine program that was developed in the early 2000s and adopted here at UNR Med in 2012. And really our goal is connecting all of the wonderful resources that we have here in Reno at the university and all across the state, as you'll find out today, with all of you as care providers and practitioners and administrative staff providing patient care and patient interaction. Really, our goal is supporting you with specific patient-related questions or cases that you want to discuss and run by our team of subject matter experts. And then our sessions also include a didactic presentation, as you'll see today, with CME and CEU credit available for those. So we will start off, we'll go around, we'll do introductions of our subject matter experts and our hub team for the day. And then with so many of you joining, I think we'll forego introductions of everybody joining us today. But if you can do us a favor and actually write in your name and your location through the chat box, and I'll send something out through the chat right now so everybody can see that. So just so we have something for our attendance records, that would be greatly appreciated. So we'll start off with our palliative care hub team, and then we'll go to the guest experts for the day. So let me find Dr. Conwright. Dr. Conwright, please go ahead.
Morning, everyone. Dr. Conwright, geriatric medicine and palliative medicine physician at the VA and program directors for the fellowships in hospice and palliative medicine and geriatric medicine. Thank you for coming today.
Thanks, Dr. Conwright. And Jessica?
Hi, everyone. I'm Jessica Kate. I'm one of the clinical pharmacy specialists at the VA. I specialize in geriatrics, and I work with the hospice and palliative team and the home-based primary care team, as well as in our CLC.
Thanks, Jessica. And then we'll go to our ECHO support staff for the day. So Sneha.
Hi, my name is Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
And Dr. Levy.
Hi, Dr. Levy here, medical director of Project Echo. I think we have Kim Anderson on too.
Kim's going to do her introduction last, so we can.
I apologize. Thank you. Sorry.
Yep. Thanks, Modi. All right. So I will actually pull up the slides, and then we can do the subject matter experts introductions because their information is on these slides. So a couple housekeeping items is that we do record all of these sessions. If you don't want to be on the video, let us know, and it's easy enough, and we can actually edit you out of anything that we post to our website. And then the other reminder here is if you do present a specific patient case, please just don't disclose any protected health information. Since we're in a group setting, we want to avoid making any HIPAA violations here today. So this is our palliative care ECHO clinic and their AIM statement. They aim to care. This is our disclosure policy, just letting you know that none of the speakers today have any disclosures that they need to make. So this is our palliative care team that you met, Jessica, Dr. Conwright, and Kim, and then this is our guest speakers for the day. So let me get, Benita, would you like to introduce yourself, please?
Hi, everyone. I'm Benita Lupera. I'm the manager of the palliative care program for Dignity Health, and I have the privilege of being the chair for the Palliative Care and Quality of Life Council. Welcome.
Thanks, Benita. And Tom?
I'm Tom McCoy. I'm the Nevada Director of Government Relations of the American Cancer Society Cancer Action Network.
Thanks, Tom. Marianne? Just a second here, Marianne. We've got to unmute you. Seems like I don't have control from my end, so you'll need to unmute yourself on Zoom. Seems like you're still on mute. So do you see the Zoom toolbar at the bottom where we were for the audio controls and the video? Okay, seems like we're having some trouble with Marianne. So Sister Katie, could you introduce yourself, please?
Yes, I'm Sister Katie from Dignity Health, St. Rose Dominican, and I'm a health educator in our community health department.
Thank you. And then Kim, if you could wrap us up and start the session for us.
We also have Sally Hardwick.
Oh, sorry, yes.
Okay.
Quite all right. Sally Hardwick. I am the founder of Nevada POLST and formerly the director of the Nevada Center for Ethics and Health Policy.
And then additionally to the presenters, we have Marianne Brown, who is the Director of Palliative Care and Clinical Ethics for Renown Health. So my name is Kim Anderson, and I am the Vice Chair for the Palliative Care and Quality of Life Advisory Council, as well as a hub member for the Palliative Care Project ECHO. And I have been the hub champion, which simply means, for this session, which simply means that I've had the opportunity to work with these exceptional and extremely knowledgeable panel to put this section together, or this session together, which is part of a two-part series that was really started and put forth by Dignity Health. So thank you, Vanita Lapera, for putting that all together. And I'm really pleased and appreciate each of you and your time and your expertise, and just really owning this and sharing it with all of us today. So without any further delay, Sister Katie, would you like to go ahead and begin our presentation?
Yes, thank you. And again, good afternoon to everyone. As I said, I'm Sister Katie McGrail from Dignity Health St. Rose Dominican. And on behalf of our neighborhood wellness centers, our Barbara Greenspun Women's Care Centers, and Project ECHO, I welcome you to our Zoom conference today for palliative care on confronting healthcare decision-making during this time of COVID-19. And we thank you for joining us today. We know your time is very important. We also know you've probably had more than your fill of Zoom sessions, but we appreciate that you made the choice to spend some time on these important topics at this time. I'm going to begin with the reflection, and since the topics are particularly important to us at this time that we're experiencing, and also even the fact that we are doing a Zoom conference instead of gathering together, I selected a reflection entitled Pandemic by Lynn Ungar that I'm going to read. So do whatever is comfortable with you. You might want to soften your gaze or close your eyes as I read this. What if you thought of it as the Jews consider the Sabbath, the most sacred of times? Cease from travel, cease from buying and selling. Give up just for now on trying to make the world different than it is. Sing, pray, touch only those to whom you commit your life. Center down. And when your body has become still, reach out with your heart. Know that we are connected in ways that are terrifying and beautiful. Know that our lives are in one another's hands. Surely that has become clear. Do not reach out your hands. Reach out your heart. Reach out your words. Reach out all the tendrils of compassion that move invisibly where we cannot touch. Promise this world your love, for better or for worse, in sickness and in health, so long as we all shall live. And Vanita, would you like to begin for us, please?
Yes, thank you, Sister Katie. Communication is the bedrock of palliative care. Discussing quality of life goals in a meaningful way for patients and families is a technical skill. Guiding those conversations to a depth that explores what is truly meaningful to the individual requires practice and presence. Reframing hope from curative to care and connection to family is the ability that provides palliation, which is comfort. Responding to a patient's questions about prognosis is an invitation to provide honest communication that allows for planning in those final precious years and months of life. Adjusting the focus from care from quantity of life to quality of life. There are specific clinical steps to such a conversation. Next slide. Let us hear from a national expert on palliative care that has been doing instruction for clinicians for well over a decade. Dr. Diane Meier.
Just as you wouldn't send a young physician in to do a surgical procedure without a lot of training and practice and supervision, having conversations with persons and their families about very complex medical decisions in the context of a serious illness is a procedure. And it requires training and practice and supervision, just as any other complex medical procedure requires. I typically approach these things, first of all, by making sure I understand this patient's medical situation, their prognosis, their treatment options, and the pros and cons. Next, I make sure that I communicate with the patient and their family that this is going to be an important conversation and that the right people need to be in the room. We have to remember that 70% of human communication is nonverbal. So it's both the space around the family and the doctor as well as the doctor's own facial expression and body language. So the first thing is to find a room which has a door that closes and is quiet. Then you arrange the chairs in a circle so people are facing each other. I always get a pitcher of ice water and some cups and some Kleenex because there's often tears and it helps people to be able to deal with that. Everyone will go around the room and introduce themselves and say what their relationship is to the patient. And secondly, I want to assure everyone that everyone will have a chance to speak and no one will be interrupted. The next step then is to ask them exactly what the other doctors have told them. And this is where you get the opportunity to hear that they've heard a lot of different things that actually don't align very well, which is unfortunately very often the case in modern medicine. This is the stage where you remember the 3 words, ask, tell, ask. And the first ask is finding out how people like to get information. And what that does is in the 90% who say, yeah, I want all the details, they have given you permission to tell them. So you have essentially placed the power and the control over the exchange of information in the hands of the person and their family. The tell part, which we doctors think should take up the entire meeting, and we spend a lot of time feeling anxious about, is actually the shortest part. The tell part is where you say, for example, I'm sorry to have to tell you this, Mrs. Jones, but the PET scan has shown progression of your cancer. And then you stop talking. Because nothing you say after that is going to be heard. It's exactly what they were afraid of hearing. You've said it, you've got to give them a couple minutes to process it. And there will be emotion. This may be when you need the Kleenex or the water. And when you've spent enough time hearing their reaction and saying, I'm sure this is really upsetting to hear, is not what you hoped to hear, you then ask them to tell you back. So that's the ask, tell, ask. Mrs. Jones, sometimes I tend to use big words or language that is medical, and I just want to be sure that I've been clear. Can you explain back to me what you understood from what I said? And then people will kind of take a few minutes, and then they'll pull themselves together, and then you'll ask them to explain back, and then they'll ask you, what's the next step, doc? There are a couple of really difficult questions that doctors dread, and the first one is, doc, am I going to die of this disease? And the right answer to that question is, barring some unexpected accident, yes, this disease is what you are going to die of. You have to understand this is not going to come as a surprise to your patient or their family. They just need validation of what they already fear and know deep inside themselves. And that's when your preparation that you did before the meeting, it comes in handy, because you will be able to explain the options and their pros and cons and how you're going to help them figure out what the best path for them is in whatever time they have remaining. A very important step that I think is often missed by busy doctors is to write down what we said. And also when you are next going to see them and how they can reach you, what number, and hand them the piece of paper. That piece of paper is you. They're going to take that home. It's a transitional object. It's a reminder that you're there for them. Because again, what that does is it takes the patient out of the role of being a cog in the disease treatment machine and puts them in the role of an active participant and essentially captain of their own medical ship. My hope is that we'll see a transformation of medical education, nursing education, other health professional education in the next 10 years so that no one escapes from medical school or nursing school without being able to demonstrate highly skilled ability to conduct difficult and challenging conversations with seriously ill patients and their families about what matters the most to them, what gives their life meaning, how can we help them achieve what gives their life meaning. That's what makes this work such a privilege, because we can help people at times like this. I hope it will restore the joy and pride in being a healthcare professional.
Welcome back. I really enjoy that video. A couple of takeaways. The ask, tell, ask. What a useful tool in practice to reduce misunderstandings. By having the patient and family tell you back what they understand, it provides an opportunity for clarification. The handwritten note symbolizes the importance of what was discussed, and it provides a reference for details that may be forgotten later. Patients and families should feel comfortable and need to feel comfortable with requesting goal of care conversations from their healthcare providers. It is up to clinicians to develop the skills to address those opportunities when presented. To discuss the POLST tool in detail, Ms. Sally Hardwick.
Thank you so much. I'll be discussing the appropriate use and pitfalls of the Nevada POLST program. You see the POLST form there, but there's more than just the form. If you're unfamiliar with the POLST, I'd encourage you to take one of our free webinars. You can register on our website at nevadapolst.org. So to my topic, the appropriate use of POLST. First, it's critical to choose the correct patients. An advance directive is for anyone over 18 in any state of health, but a POLST is only for those near the end of life. Those you would not be surprised were not with us in a year. So the frail elderly and those for whom treatments are no longer providing much, if any, benefit. This is a voluntary program. Completion of a POLST cannot be required for admission or mandated. Generally, if presented to an appropriate patient in a thoughtful, sensitive manner, as illustrated in the video you just watched, most patients will complete a POLST. The POLST must be completed after having a conversation to elicit the patient's preferences. The conversation should be an informed consent, explaining what each option involves and how it will impact the patient's length and quality of life. The risks and benefits of each option should be discussed. Then the alternatives and the likelihood of success or failure should be covered for that particular patient with their particular diagnosis. Finally, if the patient can express their wishes, then there's no need to refer to their POLST form. Pitfalls arise from the inappropriate use of. Remember, I said POLST was to be used for patients near the end of life. This is because people often change their minds about what they want once they realize the end is actually near. So completing a POLST too early may very likely result in inappropriate treatment for the patient. Instead, have that patient complete an advance directive and designate a durable power of attorney for healthcare. I mentioned that POLST is voluntary, but we know of several facilities that require completion of a POLST. POLST is in Nevada law, and it is clear that such a requirement is a violation of Nevada law. A POLST must not be mandated or required of patients. The conversation about a POLST and the form's completion requires time and resources. If the POLST is not available when a crisis arises, that time and those resources were a waste. Be sure your facility has policies, protocols, and triggers in place to assure the POLST is available when needed and transferred with the patient. Though few, the majority of lawsuits arising from the use of POLST have been for wrongful life. That is, patients received unwanted care because the POLST was not followed or not available. Next slide. Another issue is that some fail to complete a POLST if a patient wants full treatment, because that is the default. However, a large study out of Oregon showed that if a patient had a POLST directing full treatment, the patient was 25% more likely to get more aggressive care than if they didn't have a POLST. Remember, the POLST is not about limited care. It is about explaining treatments and documenting what the patient wants, whether that is comfort care or full treatment. Similarly, we know some facilities are using the POLST for code status only. Yes, everyone's heart eventually stops, but a lot can happen before that. And we want to know what the patient wants leading up to that point. Be sure to complete the entire form. The POLST should reflect what the patient wants now in their current state of health. Should something happen today, that is what they want. So if their health status changes or their level of care changes in a week or 2 months, you need to revisit the POLST and make sure the patient hasn't changed their mind about any of the options. Keep in mind, the POLST is relatively new. Oh, we can get the next slide. The POLST is relatively new and supported by Nevada law. It is very important to understand the who, what, when, and how of POLST. And with that, I hand you over to Tom, who will discuss more of the legal aspects of advanced care planning.
Thanks, Sally. Advances in therapeutic and technological aspects of healthcare have provided patients and their providers with challenging end-of-life decisions and responsibilities. Dealing with patient rights to make controlling decisions about sustaining their life without the ability to cure, or letting nature take its course. While those challenges have only been elevated in this time of COVID-19, the reality is that America's health system fails to meet the needs of those living with serious illnesses. A recent study reported by the Center to Advance Palliative Care revealed that less than 50% of those hospitalized for a serious disease were ever asked what their choice would be if faced with a critical care development. So what are the roles of the legal and medical professions in the advanced care planning process in Nevada? Lawyers are often the originators of such advanced care planning documents as the DNR. This, of course, from a legal standpoint, is a representation of the wishes of the patient, but it's not a medical order. EMTs will resuscitate even though the patient has an executed DNR. Then there's the durable power of attorney for healthcare decisions. This legal document places one's power to make healthcare decision in the hands of another. The agent has a duty to follow the desires set out in the power of attorney. The power can be limited specifically in the document. The proxy could be authorized to give consent, refusal of consent, or withdrawal of consent for care, treatment, service, or procedure. And the proxy has the right to review medical records. Power can be indefinite or short-term for surgery or travel. Notwithstanding what was set out in the POA, the person can make decisions for themselves as long as they can give informed consent. Advanced Directive for Healthcare, or Living Will, provides instructions to a person's attending physician of their wishes regarding life-sustaining treatments and artificially administered nutrition and hydration. No applicability to routine medical situations. The AD only becomes effective when there is a terminal condition, persistent unconsciousness, or end-stage condition. Voluntary and revocable attending decisions can be made. The attending physician and another doctor, however, must be involved in the care or no care decision process in an advanced directive. Most often, the AD contains a living will, of someone being named a healthcare proxy with the same authority as the person establishing the AD. The living will can also be used to direct the donation of the entire body or specific organs. We switch now to the medical side of things. There are two documents that are medical directives, medical orders. They originate with the provider and not the lawyer. Out-of-hospital DNR governs as the name applies and will be honored as a medical order. As you might imagine, it's different from the standard DNR that I mentioned just a few minutes ago. Sally has shared the important medical response to situations involving the frail elderly or those at the end of life, and that's known as POLST. Moving to this slide, we see the source of many state laws related to advanced care planning was the 1990 Patient Self-Determination Act. The PSDA is a federal law centered on Medicare and Medicaid. While the PSDA does not apply to individual physicians, it does apply to certain hospitals, home health, nursing homes, hospice, requiring such entities to provide information to adult patients upon admission. Information on patient decision-making rights, their healthcare decisions, accept or reject medical treatment, the right to execute an advanced care directive. HHS has waived this requirement during the current pandemic. So, what are the key takeaways between the legal and medical approaches to advanced care? Typically, the DNR, DPOA, and AD are executed in a lawyer's office with two witnesses or a notary, real signatures. They're legal documents. They're not medical orders. POLST and out-of-hospital DNR are created in a doctor's office by a physician, APRN, PA, real signatures. They're medical orders. Nevada has an advanced directive registry. This is a living will lockbox at the Secretary of State's office. Electronic copies are stored. A wallet card is issued with pertinent access information for the patient. Now, the provider has to complete the application and sign the agreement to be able to have access to that registry. Now, all of this may sound conflicting and confusing. Legal documents, medical orders, advanced directive. Well, the advanced directive could be and maybe should be a medical order and not a legal document. It would not require witnesses, no notary, and would be effective only if determined by at least two physicians when confronted with a life or death situation. So what approach is best for the patient, their family, and the healthcare system? Is it lawyers walking clients through the tough issues far in advance of any occurrence, taking the necessary time to help form better informed consent because they can charge by the hour? Or the same kind of conversation with a provider, but will that provider have the time and the billing code to have the conversation as thoroughly and thoughtfully as needed? Now here's Marianne.
Hi, I'm Marianne Brown. I'm the renowned Director of Palliative Care and Clinical Ethics. I'm sorry for my mouse challenges at the beginning of our program today. I'm going to talk a little bit about COVID and the impact on advanced care planning. If you could bring up the slide.
Yeah, Marianne, your audio is still a little hard to hear, so speak up a little bit more, please.
I will endeavor to speak up. Thank you. If it's too soft, please let me know. So I'm going to talk a little bit about COVID-19 and the impact on advanced care planning. As we've seen, the pandemic is rapidly evolving, and reports indicate that older adults and those with chronic medical conditions are disproportionately affected. I saw some of those patients myself today when I was rounding. What we're finding is up to a 10% mortality rate for those patients over the age of 80, and also a lot of impact to our long-term care facilities. And in some of the areas of our country that have seen surges of the pandemic, there's been an impact on ICU beds, ventilators, and the ability to care for patients. So how does that relate to advanced care planning, all of the impact that we're seeing from COVID-19? Well, it really is reinforces the urgent need for all adults to engage in advanced care planning and create advanced directives, those documents and that process that was described by Vanita, Sally, and Tom. Advanced directive execution rate for adults over 60 is really less than 50%. We also find that minorities and some cultures are much less, we find much less rates of execution of advanced directives. So we really need to do a better job. We need to do advanced care planning before patients are in crisis. And again, it should be part of those thoughtful conversations that Dr. Meier discussed at the beginning of this program. We shouldn't wait for a crisis such as COVID-19 to engage patients in advanced care planning. Advanced care planning, when done well, allows us to use our limited resources in a crisis much better. So in other words, it can reduce the need to ration healthcare resources because we've allowed patients to make choices, and often those choices are for less intensive treatment. ACP discussions, though, are not rationing during COVID-19 and shouldn't be confused with triage allocation of scarce resources. Those decisions are based on a different situation than we find when we're engaging in advanced care planning with patients. I'm going to go through a couple of scenarios of patients. These patients have been altered slightly to protect confidentiality, but I hope they help you think about the importance of advanced care planning and the prompting that we're finding as we face the pandemic. So this first case study is a 72-year-old male who was admitted for non-healing wounds and was referred to the hospital by his home health agency. The patient has a past medical history, which includes developmental delays that were then compounded by an embolic stroke. The patient also has hypertension, atrial fibrillation, and was not admitted COVID-19 positive with that diagnosis, was actually tested during the admission and found to be positive. The patient lives in a group home and has a brother and the brother's family who are involved in the patient's life. The patient, since the stroke, is wheelchair bound, and his functional status has significantly declined since that stroke. The patient lacks decisional capacity per the medical team, and the patient has no advance directive or POLST document. So what happened with this particular patient? There was a palliative care consultation. Palliative care can be critically important when determining goals of care and the plan of care with families and patients. There was also an ethics consultation requested by the medical team in trying to determine an appropriate surrogate decision maker for this patient. The brother, of course, is an appropriate surrogate as he's the patient's next of kin and actively involved with the patient. The patient's code status was changed to a do not attempt to resuscitate, do not intubate. And that decision was made with the brother and the care team with the involvement of the palliative care team and the ethics consultation prior to the patient's COVID-19 positive test. Subsequently, a POLST form was completed with the brother for a do not resuscitate or allow natural death. Selective treatment as wound care and other treatments were being sought by the brother for the patient. And then the brother also selected no artificial nutrition or tube feedings for the patient. All of that was documented clearly in the patient's POLST. The patient was ultimately discharged to a long-term acute care facility for long-term antibiotics and wound care after 2 negative COVID-19 tests. So when we think about this case, what are some of the opportunities? What are some of your observations? What are things the care team did well, or what things could the care team have done better?
Thanks, Marianne. Yeah, anybody out there, feel free to chime in about this case. Please feel free to unmute yourselves using the microphone icon on the Zoom toolbar. You can also write in through the chat box.
This is Patty Polina. The only thing I thought of is that the palliative consult could have been done even sooner, but it was correct that it was done at the time. But even it could have been done even further upstream.
Thank you, Patty. I think one of the opportunities would have been that advanced care planning could have occurred prior to hospitalization. I find frequently that there are missed opportunities to do advanced directives, to do POLSTs, to initiate the advanced care planning discussions in the outpatient setting. And oftentimes it is the hospitalization that prompts the discussion, that prompts the execution of advanced directives or POLST forms. And as we mentioned, a crisis is not the best time to be doing advanced care planning. It is much better to be done in advance of a hospital admission or a crisis.
Excellent. Thanks, Patty. Any other thoughts out there? Please feel free again to unmute yourselves or write in through the chat.
Marianne, this is Kim Anderson. I just had a question as to, can you explain a little bit more why the ethics consult?
I think in this case, the clinical team, the medical team, were just wanting to assure that since the patient lacked decisional capacity, that their brother was in fact an appropriate surrogate. The patient, I think prior to the stroke, had actually had some capacity, but at that time, the patient did not execute an advanced directive, so there was no appointed healthcare agent. So we, in fact, had to use the next of kin. And fortunately, the POLST form allows for the next of kin to sign those forms. You don't have to be the patient's agent. So I think that was the question posed in the ethics consultation.
Thank you.
There's a comment that came in from Dr. Bayan. He just says about 9 out of 10 times the palliative care consult is initiated in the hospital and not in the primary care setting.
Yes, unfortunately, most, and in Nevada, it's very clearly, most of our palliative care teams and palliative care resources are inpatient focused and not outpatient. So again, it leads to episodic palliative care instead of palliative care across the trajectory of serious illness, which would be ideal. So we're hoping that with increased emphasis on palliative care, which is another outcome of COVID-19, we now see lots of people talking about palliative care. We're hoping that that is a push to create more outpatient programs, including providing for reimbursement and finance streams so that outpatient palliative care can occur much more frequently.
Thanks, Dr. Bayan and Marianne. Any other thoughts on potential opportunities that might have been missed in this situation?
I would just, this is Sally, I would just like to add that to make it clear that if someone does have, which was not the case with this patient, but if they do have a DPOA and, let's say the brother showed up who had been attending to the patient, he could not be the surrogate. If the patient has already declared a DPOA, they would have to locate the DPOA in order to change or complete a POLST.
Yes. So Sally, sometimes a durable power of attorney or that has a healthcare agent appointed in it, that would be the person that we would be required to talk to if the patient lacked capacity. That person, though, has to be available, reasonably available and willing. So sometimes if we have advanced directives that were executed many, many years ago, those situations have changed. And so then fortunately, if those agents are no longer available, we are able to use next of kin and even individuals who understand the values and are able and willing to make healthcare decisions for patients. So the POLST gives us other options rather than just stopping the ability to do some of this advanced care planning for patients who lack capacity.
Yes,
thank you. Great
Good
comment.
Excuse me, hi, Mordechai here. I was wondering, since the POLST was kind of being filled out during the current pandemic, what kind of follow-up and kind of what time frame would you want with that POLST, if any?
So that's a really interesting question, because the execution of the POLST was actually done prior to the patient's COVID-19 positive test. The patient was asymptomatic for COVID. The COVID test was done related to the transfer, the discharge plan. So in this case, the decisions made by the brother were based on the patient's condition prior to admission, the stroke, the decrease in functional capacity. So they weren't specifically related to COVID. So in this case, the POLST was appropriate. Certainly could be reevaluated over time. For example, since selective treatment was picked, if this patient ultimately moved towards the end of life and was looking towards hospice, then the treatment would be changed to comfort-focused care.
Thank you.
All right, I think we'll move on to the second case study here.
Sure. So this second case study is a 73-year-old female that was admitted from a skilled nursing facility with hypoxia pneumonia, requiring high levels of high-flow oxygen. She was COVID-19 positive. Her past medical history included multiple sclerosis. She had advanced dementia, also underlying COPD with oxygen dependence. She was on oxygen 24 hours a day. Also hypertension. She had non-healing wounds and a really large skin cancer lesion. The patient was disoriented and had been confused and disoriented in the skilled nursing facility. So she had been deemed to lack capacity per the medical team. Unfortunately, the patient was also unrepresented with no next of kin, no family, no one really concerned or connected to this patient. Unfortunately, as someone who does ethics consultations, we find in our community a lot of patients who fall into this category of being unrepresented and not having an appropriate surrogate to help with medical decisions. Per the skilled nursing facility staff, hospice had been discussed with the patient, but because the patient lacked decisional capacity, she was unable to consent, and since there were no surrogates, they were unable to enroll the patient in hospice. The patient also had no advance directive or POLST document. The medical team really had questions about, particularly for the ethics committee, questions regarding the patient's code status. So the outcome of this case was, again, a palliative care consultation and also an ethics consultation. The ethics consultation was really related to goals of care and decisions about a plan of care for a patient who is unrepresented, for whom there was no surrogate to assist with decision making. A next of kin search was attempted to find any individuals who may know the patient. Her medical records were exhaustively reviewed. The state had had some involvement with this patient, so there were calls made to see if anyone was able to identify, again, any family, anyone connected to this patient. And unfortunately, we were unable to find anyone. So this patient lacked a surrogate. The patient's code status was ultimately changed to DNR, DNI during the hospitalization based on the concept of burden versus benefit, intubating and resuscitating this patient based on her current condition, her comorbidities, would not provide benefit to this patient. She was able to be discharged back to her skilled nursing facility because she was a long-term resident, so consent is not required. So ultimately, she went back to the skilled nursing facility once her condition had stabilized and she was medically cleared. I really hope you see a lot of opportunities or have questions related to this case, because certainly it caused a great deal of discussion for the team.
Marianne, if the patient was discharged back to the SNF, does that DNR, DNI still stand, or does she revert back to full code?
So because she lacked decisional capacity and we could not identify a surrogate, we could not execute a POLST form. So then the orders that at the skilled nursing facility would be up to that treating team in that facility.
Marianne, on someone like this, that the clinician is originally diagnosing a progressive disease that will impact the patient's cognition, even if it's several years out, like with a generic dementia, it would still, if they had done an advance directive, say 10 years prior, even if there was nobody left in her family, but in her wishes, she had said she didn't want to be intubated, would that have kept her from this situation?
Yeah, absolutely. So let's say this patient had done a durable power of attorney for healthcare. In that are statements of desire that could have supported the change in her code status. And even if she had no one to identify as a surrogate, she could have completed a declaration, which is what we call a living will in Nevada. And a declaration speaks directly to the treating physician that says, if I'm in this condition, I do not want life-sustaining treatment. So those documents would have been helpful. Certainly a POLST. I believe the patient had been in the skilled nursing facility for years, but there had been some individuals that were involved with the patient's life early on. So if advanced care planning had been done with those individuals then, we may have had a POLST form, or again, some ideas about the patient's values, and then been able to put a plan of care in place that would align with those values. Clearly some missed opportunity for advanced care planning. I think dementia, early patients who are experiencing early dementia, it's critical that we begin advanced care planning then while they still have capacity.
And that's one aspect of the POLST legislation. It says for those particular patients that have progressive cognitive decline, like this patient or someone with Alzheimer's, you can have like a 5-year, ordinarily POLST is, you wouldn't expect someone to live a year. But for these patients, you can go out 5 years. So perhaps at that point, if they had had a conversation with the patient, she could have, in a lucid moment, she could have completed a POLST, and that would have taken care of things as well.
Absolutely.
Hi, Mordechai here. I was kind of wondering, sounds like she might have been like a little delirious when she first came in with acute confusion due to her illness. I was wondering if her capacity kind of was reevaluated as she kind of improved enough to go back to her long-term care facility.
Yeah, absolutely. The ethics consultation in the recommendation were to continue to talk to the patient about goals of care and the plan of care and ongoing assessment of capacity, because as you mentioned, patients' capacity can change based on their clinical condition, based on medications, based on all kinds of things. And dementia itself doesn't mean a patient lacks capacity to make decisions, but in this case, the patient was confused and lacked capacity from the time she was admitted to the time she was discharged. Great question.
Any other comments or questions about this case scenario?
I would just make one comment. A lot of people have said that we should be doing advanced care planning specific to COVID. And what I believe is that COVID and what's occurring is a real catalyst for us to do a good job of advanced care planning for all of our patients. So those discussions should include scenarios, certainly such as COVID, but also all of the other areas of discussion when we're talking about end-of-life planning. And I think the presentation today really highlights that it is a process over time, and it starts with individuals having careful thought and consideration about what's important to them, and then utilizing the tools that we have to help document those values and those thoughts and perspectives of patients. And so as Sally discussed, making sure patients have POLST when it's the right time. As Tom described, making sure we do advance directives and declarations, and making sure that medical teams, hospitals, people who provide care, your family, have all of those documents for when a patient needs them.
All right, so we've got about 9 or 10 minutes left, so I'd like to open it up right now for questions about this presentation today, or if anybody has a specific case in mind or patient that you want to run by the team for some input on. So please feel free to unmute yourselves or again, write in through that chat box. Thanks so much, Dr. Conroy. So we are right at time for today's session, so I just want to kind of start to wrap up everything and thank everybody, all of our great subject matter experts and guest speakers for today. Really great information that you shared with us. So I sent one link out through the chat box, which was the Vital Talks website that Dr. Conroy mentioned. The other link in there is to sign up for our ECHO mailing list, so you can actually get reminders about all of the ECHO programs that we have on offer throughout the weeks. And then I'll take us to our palliative care ECHO website here. I'll also send the link for that through the chat box. And this is where you'll be able to retrieve the slide deck from today's presentation, as well as complete the CME or CME evaluation form, or CU, excuse me, to claim credit for today's session. So again, this is our website here, and if you just scroll down a little ways, this link here will download the slides for you, and then this link will take you to that form to claim CME or CEU credit. And you can also see what else we have coming up through the series. So our next session is going to be on June 19th with Dr. Vrogan and Dr. Meier talking about nausea and vomiting. So we hope you'll join us then. Also on here is the case review form. So if you have a specific case that you want reviewed by the team, you would go there and submit that to us. So yeah, we are at time, and we understand if you need to take off, but I'd like to, leave a couple more minutes here for people to ask questions if they do have any.